Hi everyone, I'm Ashley Bassett.
And I'm Catherine Logan.
And welcome to the Sports Talks podcast. On each episode, we chat about the most recent developments in sports medicine and dissect through all the noise so you know which literature should actually impact your practice. Today, we're coming to you live from the American Orthopedic Society for Sports Medicine annual meeting in Washington, D.C.
The AOSSM annual meeting is the premier sports medicine conference each year, hosting over 3,500 attendees with hundreds of posters and paper presentations, exhibitors, and instructional course lecturers. This year proved to be as spectacular as years past. We were fortunate to have the opportunity to catch up with many of the presenters at the meeting and get their take on some of the hottest topics in sports medicine.
Over these 7 episodes, we're going to be exploring some of the hottest topics in sports medicine with these experts who are presenting at the AOSSM annual meeting.
We are supported by Stryker. Seeking a clinically proven solution for your patients with massive and irreparable rotator cuff tears that has the potential for early functional recovery and pain relief? Check out InSpace.
InSpace is the industry's only minimally invasive, biodegradable subacromial balloon spacer for the arthroscopic treatment of massive irreparable rotator cuff tears. InSpace is designed to restore the subacromial space without requiring sutures or fixation devices. Learn more at stryker.com/InSpace.
We have 2 amazing guests for you today. We have both Dr. Nikhil Verma as well as Dr. John Tokish. Dr. Nikhil Verma is the Director of Sports Medicine Division and the Sports Medicine Fellowship at Rush. He is also a head team physician for the Chicago White Sox and team physician for the Chicago Bulls. He will be discussing the use of the Stryker InSpace balloon to treat irreparable posterosuperior rotator cuff tears.
Dr. John J.T. Tokish is the president of the Arthroscopy Association of North America and the director of the Sports Medicine Fellowship at the Mayo Clinic in Arizona. Dr. Tokish will be speaking about the biceps smash technique using the long head of the biceps tendon autograft to biologically augment rotator cuff repair. So we're excited to hear what these 2 gentlemen have to share with us today. So without further ado, let's get to the exhibit hall.
Okay. All right, Nick, JT, thank you for joining us for this special episode of the Sports Talk live at AOSSM in Washington, D.C. So welcome to the show.
Thank you. Thanks for having us.
Thanks for having us.
Yes, happy to have you here. So our discussion today focuses on 2 different surgical techniques for management of complex rotator cuff injuries. First, the biceps smash technique to augment rotator cuff repairs that are repairable, and then second, the Stryker InSpace balloon to address massive irreparable rotator cuff tears.
Okay, so JT, let's start with repairable tears. So you are presenting tomorrow on the use of biceps autograft patch augmentation for rotator cuff repair. So tell us a little bit about your indications for adding a biceps autograft.
Yeah, so as you guys well know, we are not winning when it comes to rotator cuff repair outcomes, right? So there have been a number of studies in the literature, but I think the take-home point is in spite of incredible advances in mechanical techniques and the mastery of the mousetrap, if you will, biologically, we're still seeing 25 to 30 to 70 and even up to 80% in large tears in certain patient populations. So that's led to this incredible rise in getting us all to try to think about how to augment or improve those rates, right? And we now know it's no longer a mechanical solution. I mean, we can go triple row, quadruple row, I mean, whatever you want. You watch Nick operate once in a while, you can see it can't be done any better than that, right? It looks like stitching on a beautiful Armani suit when he's finished with it. So if one of those fails, you know it's no longer a mechanical issue, it's the patient's biology. So how do we augment that, right? So there's all kinds of augments out there. There's xenograft and of course allograft, but the best thing we can put there is a tenocyte, right? That's the thing that is most attractive to your own stem cells to mobilize and turn into what we want them to turn into. So that was the impetus of the idea. So what's the indication is any cuff where you feel like you're at a high risk of failure. Now we could argue that's every darn cuff, right? So Rohe scores and everything else when we get above. But if you've got an older patient or somebody that you think is repairable or at risk, and that's increasingly a high number, that's what got us thinking about how can we augment this and what's available and what's doable.
Who are you deeming to be high risk for those? I know we talk pretty much every cuff tear is at some risk, but who do you determine to be high risk?
I think that, one of the sort of early goals we did was we look at a Rohe score, published in AJSM in 19 for those that want to look it up. But essentially, it's a scoring pattern that takes a look at all the major risk factors and combines them together. The score is 0 to 15. If you're above 5, you got a 50% chance of re-tear, or I prefer to call it failure to heal, right? So that means over 70 retracted tears, 2 tendon tears, Goutallier changes, all the usual suspects that you and I are very familiar with in our practices. So if you've got a cuff and you look at that and you say, wow, older patient, bigger tear, Goutallier changes, smoker, any of those other biologic things, I think that's the one. Now, once you get sort of into the weeds on that, well, then who isn't, right? And then if you have a biceps that's available, many of us do biceps tenodesis on every case. And so one of the big things is to say, well, gosh, if you've got it, why wouldn't you use it? Is there a downside?
Right.
Absolutely.
And so obviously, Nick, there's autograft options, there's allograft, there's xenografts that JT just mentioned. Are you utilizing these, and how do you determine the appropriate patient?
Yeah, so I think about it in the same way that JT does. I think the biggest limitations that we have right now in the ability to augment the way that he's talking about, meaning some type of a structural augment, usually over the top, although maybe there's room for an interposition augment, which I think makes a little bit more sense to go in between the tendon and the bone in terms of what we're trying to achieve. The biggest limitations are cost, complexity of the surgery, and indications, and none of those problems are solved, right? The costs are anywhere between $3,000 to $5,000. That's certainly not scalable in today's environment to use with every rotator cuff tear, even though we may think that's an advantage. The technique is challenging. There are some techniques that are evolving that are out there that are making it easier, but it's never easy. And then finally is the indications. And so for now, based on those limitations, I think about this as in 2 patient groups, right? We have the patient group of the younger, active individual who is really prioritizing strength. And for those patients, I think we need to do whatever we can to try to get healing of the rotator cuff, because in my mind, that's the differentiator between a good outcome in a healed cuff and a good outcome in a structurally deficient cuff, is both get pain relief, one gets better strength and functionality than the other. And so in my mind, for all of the factors that JT just listed, a high-risk patient with a larger tear size and poor quality tissue, and maybe some biologic factors such as hypertension or other things that predict failure, those are the ones that I would augment with some type of a patch technique.
And we've brought it up on the podcast before, smokers. Are you doing rotator cuff repairs in smokers? Are you testing them, or do you say no? What's your stance there?
Yeah, so my take on that is that you can say no all you want, but you're not going to change people. I spent 4 years practicing in Stephen Hawkins in South Carolina, and if I didn't operate on smokers, it'd be a lonely day, right? So now I'm in Scottsdale, Arizona, where every 80-year-old's 50, and as healthy as can be. But at the same time, I think smoking is what it is, and it's one of those things, sure, we should talk to our patients and counsel and do our best to talk about it, but I think going so far as to say refusing, I don't know. And we know that the data, even if your cuff doesn't heal, patient outcomes do get better. So I don't think it's reasonable, at least in my hands, to withdraw that opportunity to do the case. At the same time, we want to encourage them to stop, but it does make me more likely to think about their biology a little bit.
Are there a lot of smokers in Chicago? I actually don't know the answer.
It's interesting, right? I mean, the demographics are certainly changing. I don't know how vaping affects this, but that's the big thing among young people, and that's probably a podcast into itself.
Sure.
I think the older demographic certainly does carry a higher risk of smoking. I think that the data is mixed in terms of how that actually affects outcomes. I think across the board, when we look at things like diabetes and smoking or renal disease, they obviously are poor prognostic indicators. But that's just not the way medicine works, right? There's a lot of different things that we could say. We're not going to treat you unless you change your diet, unless you stop smoking, unless you lose weight. And if we did that, we would be doing a disservice to society. So obviously education is important, counseling is important in regards to, here are the reasons why it's a good idea for you to help or to stop smoking, or we're going to try to help you to do that, but you can't refuse care, in my opinion.
That's a good point. So we talked about all the benefits of using the biceps autograft. So it has that parallel collagen orientation, it's biologically active, it has the tenocytes that you mentioned. So can you walk us through your surgical technique, your approach to harvesting the tendon, how you prepare it, and then how you secure it to the rotator cuff?
Sure.
You forgot the main one, which is it's free.
It's free.
I know, and I actually did have that listed.
I forgot that.
Yes, it is
free. You got to be on your toes with
JT
Verma.
loves free.
Yeah.
JT loves free.
Yeah, so I'm a military guy. We don't get paid anything, so Yeah, so the cost is obviously a big deal, right, with
Yeah.
these patches being there,
Sure.
and it's almost readily available unless somebody's already done one. But I've even done ones where they've done previous super pecs and gone after and gotten them again. You can always go sub pec. There's always plenty of tendon. So how does it work? Well, most surgeons are familiar with their normal process of going through, and most will do a biceps tenodesis in conjunction with their cuff. So whether you do or you don't, the biceps tenodesis can be exactly the same. The one typical technique that you can't do is the extremely high intra-articular one,
Okay.
so that you do need about 27 millimeters for the graft. So think 25, 2.5 centimeters of graft. I do a arthroscopic super pec right above the pec major tendon, which is all part of the same. I'm lateral to cube. It's very easy to see. And getting into that subdeltoid space is a little learning curve for most people, but it's the way we do all of our tenodesis. If you do an open sub pec, you're fine too. And essentially you take that hunk of tendon that you would normally throw in the trash. And I think that's the beauty of this technique, is that normally you throw this in the trash. Well, all you do is go back, measure 27 millimeters of it, chop it, and stick it into what is now called the smasher, or a plate. That plate is the same, is a commercially available plate. Arthrex makes it. And then you put that plate under compression. Now the compression device is exactly the same device as they use for their shoulder arthroplasty equipment. So most surgeons are familiar with companies that will add on the post, and then they'll press fit the post to the base plate. So same instrumentation.
Okay.
So you stick that in there and you crank it down to 4 minutes. After 4 minutes, you take off the tension and you pull it out, and it is uncanny. I didn't invent this, so I don't have a dog in this hunt. I will just tell you that the patch that comes out of that compression process is gorgeous. It looks just like all the other commercially available patches. And then I guess the thing that we've sort of started looking at, in addition to the clinical and MRI work, is we worried that we might hurt the tendons or destroy the tenocytes with that process, and that's what our presentation is here, is talking about that we are able to save, it's 95% and not different than the non-smash stuff. So it's alive when we put it in.
That's great.
Yeah. And as far as, there's no, so once you take that tendon to the back table to prepare, you are not opening it up and exposing any sort of the cell. Basically, you are just smashing it.
Yeah, but it's the biceps tendon itself is quite porous, and so we showed this in a previous study on this topic where we put it through a skin graft mesher, and even those that we didn't, just the raw tendon itself, the tenocytes will go depending on the milieu and depending on the paracrine signals that they receive. Interestingly enough, the strongest paracrine signals are other tenocytes. So if you've got tendon in the area, those things, you can actually see them walking, if you will, with their little tenopods crawling over to the site of repair and regeneration. So obviously we got a lot of work to do before we show that but it's a nice option.
Now you mentioned
have
that.
to try and get like a visual of that.
Yes,
So
for
we
the
do.
YouTube.
These do go on YouTube, and
Right
we
on.
insert some good visuals. But like the walking tenocyte is something we haven't done.
Yeah,
So
we'll ask our cartoon guy to draw us some cartoon tenocytes. So you mentioned that it's a porous scaffold, so it can allow tenocytes to migrate, but that also should allow some biologics to be kind of implanted there. Are there any current studies looking at the use of biologics with this patch? Do you add biologics to your patch?
Yeah, so there's one really good basic science study in the literature that looks at adding PRP to a biceps milieu and showing that it increases tendon differentiation and stem cell migration, etc. And so it's very easy to take this patch and soak it into PRP. Any of the other biologics that are out there right now, to my knowledge, have not been studied. So, I look at these things, sometimes people say, well, we're going to use mesenchymal stem cells and exosomes and all these crazy things. And I say, well, what's your purpose in that? Well, because those things can turn into tenocytes. And I go, right.
Yeah,
We start with
got those.
tenocytes. That's what we're looking for. But I do think there's a role of PRP. But then the other side of this is that, the biceps structure does not have structural sort of strength to it, right? So it's not a mechanical thing. You could imagine putting these in mesh patches and smashing them together as kind of a construct together, and then you might get the best of both worlds, and I think that's where we're going.
Nick, do you have any thoughts about that with biologics and any of these augments?
Yeah, I think, again, the goal is, the problem with biologics as I see it now is we've got three fundamental questions, right? It's what to use, when to use it, and how to deliver it. And we are no closer now than we were probably 5 to 7 years ago in understanding those. I think that obviously what we know is, especially when you're using products like PRP and BMAC and other things, at least they're safe.
Right.
They're autograft tissue, and there's no downside to doing it. The big downside is, again, increasing cost of the procedure based on the kits that are required, et cetera. But I think what JT will probably show us is that as you do soak these patches, that based on the fact that you've got living tenocytes and you've got an architecture there, is that you will see some cell migration and adhesion to these implants, which at least maybe makes us feel a little bit better about delivering them rather than just squirting them in and closing the portal and saying that it's going to do something. So I think we do have to think about these not only in terms of augmentation from the structure they provide, but how do we start to get to the point where we can use them as delivery vehicles as well.
We just talked about this. We just had Scott Rodeo on to talk about biologics, genetically engineered biologics. But he was talking about that. You can't just inject it and cross your fingers and pray and hope it stays there. You have to give them a system to.
We're here to bring
stay.
down the mean of the IQ after Scott speaks, so I think we've done that accordingly.
JT, have you looked at the biomechanics between a dermal patch, for example, and the biceps patch? Do you think it has some structural integrity? To me, when I've held it, it certainly feels more than the xenograft patches that are out there structurally.
Yeah, so I think it does have more of that. We looked at that with the original skin graft. It does add some mechanical strength, but the truth is, I think, is unless you're attaching it to bone, you're putting one side of that to muscle. So I don't care whether you can put stainless steel in there; it's going to pull out of the muscle, right? It's not going to give you any additional strength from a structural standpoint until it heals. So I do think there may be a role of after it heals that maybe the re-tear rates might go down, not only biologically but somewhat with that strength. But I could imagine this as having a role with SCRs down the road, where you would include the biology of a biceps patch in one of those polypropylene patches that are going to kind of meshes, if you will, that are going to sort of take over the world here pretty quick.
Yeah, absolutely. Awesome. So I think now we want to transition to talking about the balloon, but before we talk about its main indication, which is treatment for irreparable cuff tears, I wanted to quickly talk about treatment for repairable tears that are massive. There is some talk of surgeons using it to either compress the repair tendon down onto the tuberosity or kind of shield the superior aspect of the tendon from abrasion in the subacromial space. What are your thoughts on that?
Yeah, so just to be clear, it's off-label indications, what we're talking about now, and I think you did an amazing job of presenting this in the beginning when you introduced JT and I in talking about JT's biceps concept for repairable tears and the balloon for massive irreparable tears. Because as much as I like to argue with JT, and I usually lose because he'll cite every article that's been published in the last 20 years, including the volume and page numbers.
Mostly I'm citing his work, though. That's the problem.
No, but I think it's a different patient population, right? So we just had a lunch and learn session talking about the balloon, and this topic came up, and so I really think, as orthopedic surgeons, we get a widget and we just want to figure out how to use it, right? And so we decide, no, maybe we'll try it here and maybe we'll try it there. But I think we need to take a step back, which is to ask ourselves, what's our goal of doing this? So if you're just going to put the balloon over the top of a tendon, what's the goal of doing that? Is it accelerated rehab? Is it improved healing rates? We probably will not see any difference in clinical outcomes because we can't tell the difference between a healed tear and a non-healed tear. So what are we trying to achieve by doing that? I think it'll be really difficult for us to see better healing rates, and I'm not sure I understand the concept of how that may occur. I think that if they don't heal and you have the balloon and they do well, then maybe you should ask the question, should we use the balloon alone? Could it be a delivery vehicle for biologics? I guess it potentially could, but I'm just not sure I see yet what is the rationale for using it over the top in terms of what are we trying to achieve clinically. I think for me the bigger opportunity is to take these patients. We all see these older patients, and I don't know how to define old. Maybe 65 and over.
Easy,
it's I know you know it when you see it. And for me, it's more not about the age or the physiologic nature of the patient. It's what do they want, right? And for many of these patients, it's pain relief. For some of the patients that I think JT is talking about, it's functional recovery, and I think those are two very different things. So if you've got a lower demand patient at an older age, let's just say that word, that wants pain relief, then maybe we have to get away from this thought that we have to repair the cuff, we have to repair the cuff, we have to repair the cuff, because we know that even when the cuff fails, they do pretty darn well. So I think the expansion of the balloon in the future is to start looking at what we would, because the study was massive irreparable tears.
Right.
But what about large mechanically repairable tears that are biologically irreparable or biologically at high risk of failure, and saying, can we get a similar result by just putting in a balloon but having a 12-week rehab instead of a 9-month rehab?
Sure.
That to me is the bigger runway here.
Absolutely.
Yeah, and I think you're speaking about indications. So if we can sort of like dial that in a little bit for you specifically in your clinical practice, when you're talking about the InSpace, what are your indications?
So this is a very, very specific patient group, and if I had to define it, it's physiologically and biologically older, and the number that came out in the study, at least from the data that we had, was 65 and older. Number two, they have to have well-preserved function, so at least 90 degrees, but honestly most of these patients have near normal elevation. They have pain as their primary complaint, and they understand that they may not get strength recovery, but they'll get pain improvement. And they have to have a Hamada 1 or 2 with absent to very little osteoarthritis. So, when you think about how many patients come into your office with those criteria, it's not a lot, which is why I put in, 15 or 20 balloons a year. It's not hundreds and hundreds of balloons that are happening. But there are these patients that, in my opinion, used to be a donut hole, where we would see these younger patients where we would be eager to repair them. We'd see the patients that had more advanced disease with either functional loss or arthritis, where reverse works amazingly well. But then you see these patients who are of an older age group who come in and they raise their hand completely all the way up, and they can do all the things that they want to do. They just say, it hurts. I can't sleep at night and I have pain. And those are patients where it was a little tricky, because you do feel like in a normal shoulder, to put a reverse in those patients, yes, it works. They may lose some motion, particularly with internal rotation, and it might be overkill for what they're really looking for from an outcome standpoint.
So you talked a bit about kind of indications for you. So how does the balloon work? How is it taking away that patient's pain?
If I could understand that, I would ask the same.
Ask the stumping questions.
Yeah, no, I would ask the same question about how does SCR work, how does tendon transfer work, how does failed rotator cuff surgery, and when I say failed, as JT pointed out, it's structurally non-congruent rotator cuff outcomes. So I think we have a lot to learn in terms of where the pain is coming from, but the way I think about it is that in large part we know that if we were to MRI everybody in this room right now, that a significant number of them would have a rotator cuff tear and functioning just fine, right? And frankly, many of the people that come in and are candidates for the balloon procedure have existed with rotator cuff deficiency for many, many years, and for whatever reason have now become decompensated. Maybe the tear got a little bigger, maybe they overdid it. Many of those patients will respond to an injection of PT, which is another question, right? Why should that work if we haven't fixed the rotator cuff? But I think what they need is a little nudge. And so my opinion is that the balloon works much like an interposition. So I do think that there is some reality of pain between contact of the humeral head and the acromion that you reduce by temporarily eliminating that or re-providing that space. And I think that there is some just period of painless or pain improved rehabilitation that allows them to go back to the compensated state.
Yeah, and I guess if we kind of back up a little bit for both of you with this sort of irreparable cuff tear, like what are those first steps? Are you injecting them? Are you trying cortisone? Are you going to biologics? Are you doing PT? What's the first sort of steps for you, JT?
Yeah, it's unfortunately it's a long discussion now, right? It used to be either sorry before reverse came out when I was a boy, or it was, but of course now it's everything under the sun. We give an algorithm that we take them through, and many patients come in with weird notions. They'll come into me a lot of times and say, well, wait a minute, I heard you do a lot of amnion stuff. How about amnion in my shoulder? And then you're like, oh man, it's going to be a long day discussing about these things. So I think that the discussion that patients have where we start with it is kind of where they've been. So have they already done therapy, right? Because we know Ofer Levy's work of patients with massive irreparable cuff tears, it may be the best results in the literature, and they just did simply therapy. Yeah. But I think that the key mark for me, if the patient's obviously there because things aren't working, they're not happy. So then the question becomes, okay, my first question for you is, can you do this or not? Can you lift your arm overhead or not? Are you functional? Because if you're functional and you have pain, well, then we've got all kinds of things I can give you. And injection's the quickest and the easiest because you're here. We can knock that out. You go home maybe happy. And maybe that's all you ever need. Maybe we send you to physical therapy. But I think that particular patient, that is functional but has pain, well, we want to do the least invasive thing possible that will give them pain relief. And I think that's the niche that Nick brings to it. He's actually the one that brought the actual science and logistically reasonably way to think about it is, look at this patient, that's the patient to do it in. I think there's crazies, I'm speaking about orthopedic surgeons now, on both ends of the spectrum. The zealots who say, well, I don't understand how clearly this works and it's temporary, so they should throw that out. Right. I think that's a little bit ridiculous. And I think on the other hand, you've got people that are starting to go, ooh, baby, do I got a new toy I'm going to throw this in,
Everybody,
and that's
yeah.
a little ridiculous too. So
Yeah.
somewhere in the middle.
Yeah, I think there's some concerns, at least that about people overusing it in tears that may be repairable. You know, people look at it and say, oh, you know, instead of doing all the interval releases and trying to mobilize it as best as possible, throwing that in. But I think in the ones that it's irreparable, it really has a good role.
Yeah.
Right, Catherine, what do you think?
Yeah, no, absolutely agree. It's a part of my practice, and kind of,
Me
I
too.
think you said it perfectly, GT, where it's like, it's not my whole practice,
Yep.
and I'm not sort of saying, hey, there's no need for it. It's, you know, really understanding the indications, who's going to do well with it.
Yeah.
But I think it fills a nice gap, you know, and I
does.
think, so we should talk about the data then.
So the first thing I want to say to your
Yeah.
question about biologics is, JT, you can tell me if this is your experience, or Ashley or Kathleen.
Yeah.
The more a patient comes in wanting biologics, the less likely they are a candidate for biologics.
Yes.
And the longer it's going to take you to get out of that room.
Yes.
That's the worst situation.
I think
No, it's
people,
interesting.
I think they think it's a magic wand, and I
God.
joke with
Yeah.
people too when I'm like, let me take out my magic wand. It's not understanding what problems can be fixed with biologics, what the indications are. As you kind of highlighted, we need to know what to use, when to use it, and how to deliver it. And patients just think if you inject amniotic stem cells into their knee, poof, their meniscus tear is going to heal. It doesn't work that way. So I don't
And
know.
at least we potentially have some evolving data to suggest that it may help in situations like rotator cuff repair or allograft reconstruction. We have zero data to suggest that if you just give them a shot of BMAC,
Yeah.
they're going to be better.
Exactly.
And they want it.
Yeah, absolutely.
Yeah. Well, I will say about 2 weeks ago, I had a retired general surgeon come in my office for basically irreparable. Like he needs a reverse, and but he said, I'm just coming in to talk to you to see if like PRP has a role. I've heard it has, and da 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 da. And I said, I couldn't do that. I have no idea how that would help you, and I'm sure you'll find someone in Colorado that will inject this, but it's not going to be me. And about 4 days later, I came to the office, and on my desk was a bottle of scotch and a thank you card for not doing anything.
Yeah, about that.
And I thought, there you go. And he said, appreciate your honesty.
Yeah.
Right. Very important.
We just going offline here, we just did a study where we had one of our research assistants cold called practices to find out what the cost was of biologics.
that's so
So they called and
interesting.
said,
Tell.
my dad has lateral epicondylitis or has lateral elbow pain. He's been told that he needs an injection. Do you do BMAC? Do you do PRP? Do you do et cetera? What does it cost, and how much does it cost? So what we found was that almost universally the costs were very tightly grouped within the orthopedic community, but they were all over the board when you went to the other category, which is chiropractic centers, stem cell centers, et cetera. So it was really interesting data to just say that there's such a market out there that's based on a procedure that's unregulated and fee for service. The good news is that I felt good about was the fact that the orthopedic community seemed like they were very responsible in their way that they were pricing and providing information on it.
That's great.
Yeah, it's like anything can be called a stem cell, right?
Yes.
Stem cell IV infusions and things like that, which it's not actually, has zero cells. So awesome. So before we talk about outcomes, because I have more to chat about that, I want to talk a little bit about surgical technique. Obviously, we looked through the technique video. We both do that procedure, but we want to know if there's any tips, tricks you have for surgeons that are listening as to how to make this procedure go seamless, how to make sure the balloon doesn't migrate, any tips that you have.
Yeah, so I have to, for those who are here at AOSSM, there's a talk tomorrow on the technique, and they gave me 6 minutes, and I was like, what do you want me to do to the other 4 minutes? Because this is going to
Same
be about
question he asks when he does SCR, too, just so you guys know.
This is going to be like a 2-minute presentation, but I think there's a couple things. Number one is by far and away, and what we're going to talk about a lot tomorrow is the indications for the procedure, because that's really how you make it successful. There's some debate about lateral or posterior portal insertion. We have seen that there can be some increased risk of balloon migration with posterior portal insertion, and it's because the balloon is a pillow. It's not a cylinder. It's not a sphere. So it's longer in one direction than the other, and it's designed for lateral insertion. I don't know that it can't work posteriorly, but maybe a consideration. I do smooth the acromion. I don't release the CA ligament. I smooth the tuberosity because, as I talked about, I think there's a role for smoothing the articulation between the acromion and the humerus eventually when it's going to happen. I deal with the biceps usually with a tenotomy because I don't like slowing them down with the rehab from a tenodesis, and I think the biceps is a pain generator. And then we try to minimize the bursectomy by not overly creating a large space for balloon migration. And then the last tip I would say is that if you're in between sizes, just size up because you want the balloon to fill the space and you don't want it to displace into the anterior or the lateral gutter. But from a technique standpoint, it's not hard.
Yeah, absolutely.
All right, so finally we're just going to close with a little bit of talk about the data. So as far as, so Nick, you published a multi-center RCT that was in JBJS last year, and you compared the InSpace implant to a partial repair for treatment of full thickness massives. So tell us a little bit about your findings.
So first of all, the design of the study was pretty complicated, and we got a lot of pushback on that. Many people said we should be doing debridement, others said we should be doing SCR, people said we should be comparing to reverse. And that just speaks to the fact that there is no gold standard procedure that would be considered, the control group in here. We chose partial repair because we felt that it was very equivalent to the invasiveness of the procedure that one would be doing with the balloon, that the rehabs were very similar, and that the patient characteristics of who you would choose to do that would be most appropriate. And frankly, surgeons weren't excited about randomizing people to debridement alone, so we felt there would be a hard time to getting people to enroll, although maybe that has some value. What we found was that there was really no statistical difference in any of the patient-reported outcomes at any time point between balloon and partial repair. So you may say, okay, well fine, then we should just be doing partial repair in all of them. But what we did find was that there was earlier improvement in the patient-reported outcomes in the balloon group, and that the balloon group was very much more range of motion friendly. So there were less patients that lost range of motion or got stiff. And when they did lose motion, they lost less motion compared to the partial repair group. There were more patients that gained motion, and when they gained motion, they gained more motion. So I think about this as an MIS type option, right? We're all trying to get to the same place, which is functional recovery and pain relief. If you're a patient and I have a procedure that requires a 2-week sling immobilization and an 8-week rehab, or a 6 to 9 month rehab, which one are you going to choose? And so I think that even though the study looks at equivalent outcomes, the time frame over which you get there and the burden of rehab and the surgical complexity, I think, are real critical advantages for the balloon over a partial repair in the right patient population.
Can you tell us a little bit about the longevity of the data as it relates to the degradation of the balloon? So something I hear from people all the time that are skeptics is, well, the balloon degrades, it doesn't last, so how are clinical outcomes going to last? But your study and other studies have shown good outcomes.
Yeah, so the material is PLA, PLC. It's a very, commonly used material. It goes away relatively rapidly via hydrolysis. The balloon is probably deflated by 3 months, and it's typically gone by 12 months. The data in the study was up to 2 years, so that shows you that it doesn't matter that the balloon is not there. And the midterm follow-up is now happening, which is up to 5 years. We had about 90 patients in each group, partial repair and balloon, and only 2 were revised to reverse in both groups. So it's a pretty challenging patient population. We had about 80% meeting MCID, 80% meeting PASS, and about 60% meeting SCB, which are, that's a hard measure to meet where you're completely asymptomatic. But the majority of the patients did feel that they were better and they were happy with their outcomes.
I think, you're both doing really amazing things for 2 different populations. So for our last sort of piece, can you share what is on the horizon for you both as far as where are you taking your research? What do you think is an area that you need to evolve to keep pushing your goals forward?
Yeah, I think that there's a number of areas where autograft tissue that we normally discard or taking autografts can be used all over the body to sort of regenerate, reuse, and God put it there for a reason. So we think that this may be a good paradigm to kind of go with. So for example, when I do anatomic total shoulder arthroplasty, we know subscap takedown and subscap failure after that is often a problem, and that's a natural one. So we add a patch on every single anatomic that we do. I do a biceps tenodesis with those, and that patch now reinforces the subscap. So some of our research that's coming out is, does that lower the rate of tear, re-tear as well? And we've got the obvious studies ongoing about, outcomes and re-tear rates, et cetera, in MRI after shoulder. But, we think that there's probably options down the road for when you remove that patellar tendon graft, if you maybe take it, one of the devices that's out there, and I'm conflicted on this, but we can insert tissue. So this is what we do with some of the umbilical cord stuff. So for example, we'll take some of that umbilical cord inserter and we'll put live tendon in there. So if you've got patellar tendon, you can put a little streamer, if you will, of tendon and put the tendon in there as well, and that's autograft tissue. So I think there's a number of ways we can adapt autograft tissue to take advantage of the body's natural stuff to get after it.
Do you yet know the trends of your biceps data on the subscap?
It'd be too early to really say. I mean, we haven't seen
previews.
Yeah, we haven't seen a single failure yet.
Okay.
But that's what everybody says. Everybody thinks their baby's cute, so we gotta be careful about it because we all know.
Fair enough.
Yeah.
All right, Nick, same question.
Yeah, I think JT said it best earlier, which is we can't build a better widget anymore, right? We've gone well beyond what the mechanical forces that are necessary to repair a rotator cuff, not necessarily heal it. And when we see failures, they're not because anchors are pulling out or sutures are untying it. It's biological. And so I think what's interesting to me is how do we partner with our industry colleagues to create vehicles that allow for both mechanical repair with some form of biologic augmentation in a way that doesn't really change the technique. Because the problem is, if you add 30, 40 minutes to a procedure, the technical ability to get it done, it just becomes very difficult to scale in any meaningful way, versus if we can just take some of the things we have now and make the repairs look and feel like we do now, but get some biologic augmentation along with it. On the balloon side, I really do believe that, as surgeons, unfortunately, we're just hung up on this concept that we have to get structural healing. The tendon has to be repaired, and I just don't think that's true. And so I do think that there'll be runway in the balloon, and we're looking at starting a randomized trial at Rush now to say, okay, what about large tears that are mechanically repairable, but probably not going to heal? Because this study was really tears that we felt were mechanically not repairable. But what do you do with the 74-year-old who has Hamada 1, good range of motion, a 3.5 centimeter tear, poor quality tissue, but we can definitely get it to the medial aspect of the footprint? Is that really the right operation for that patient? And I think maybe there's a role to expand.
Some of those comorbidities.
Exactly.
Yeah.
I think there's a role to expand to say, maybe if we have something that's simpler and still gets them good pain relief at an earlier time point, that we should think about that.
The other thing I think is interesting about what Nick's done, they handicapped themselves because they had to when they did their randomized trial, and that they kept the rehab the same for both groups. I think there's a huge difference between a patient that you let move right away, which his balloon will allow you to do, versus those that we have to immobilize. Grandma and Grandpa, I learned this with subscap for reverses. I don't repair them because I move them early, all of them, and my results have changed my life with that. I think the same thing will be found when they can move those guys earlier after these cuff options.
And I think we're already seeing it with the range of motion differential that exists, even though we kept them for 4 weeks. What was really interesting was the patients who had had prior rotator cuff surgery on the other shoulder. They would come in at their first or second post-op, and they'd be like, I got the balloon.
Yeah.
Right.
For sure I got the balloon, because they just could tell the difference in the way that they were moving and functioning at that early time point.
Well, and I can tell you, as my first career as a physical therapist, even in the late 90s, there was a lot of differentiation when how surgeons would write their protocol as far as like early motion, and there's people that were a lot more conservative than others. And I tell you, the patient, there was such a difference in the happiness, when they
Well, you guys see it every day, right? We see them for 5 minutes at 6 weeks and 12 weeks and tell them to hang in there. I mean, you're dealing with this.
Right.
The emotional component of the recovery that is just draining for a patient.
Well, I was also a therapist in the age of everybody got a slap repair.
Yeah.
So that was
Everyone is
God bless you. You deserve sainthood for that.
very different. Anyway, we know we've kept you over.
Yes, please.
But we are so honored to have had you today, and
Thank
Love
you
the
so much for
concept.
taking time out of your very busy
Great
schedules
job,
to be
guys.
here.
Congratulations.
Thank you.
Congratulations. This is
Yeah.
awesome.
Thank you.
Yeah.
Thank you for listening to this episode of the Sports Talks. We hope you enjoyed the discussion as much as we did.
Make sure to subscribe on Apple, Spotify, or wherever you get your podcasts to stay up to date on all things sports medicine. Exciting announcement, we are also now on YouTube. You can find links to all of our social channels and our contact information on our website, www.thesportstalkspod.com. We love to hear from you.